Very quickly as a review, just remember, there's not a continuum. Type 1 does become type 2, become type 3, and type 4. And we're really talking today about Chiari type 1 malformations, which are certainly, the most prevalent in our practice and the ones that I think generate the most discussions. Not to forget that we continue to add to this list. There's a type 0 and type 1.5, which I won't address today, but I will say I don't think either of those is amenable to non-dural procedures. I think if you could talk about non-dural opening, you're talking about type 1 or, and certainly I think quite possibly Chiari type 2, but intrinsically type 0 is probably not a issue of bone or dural compression, but something intrinsic like a web that's causing a problem, which can't be addressed extradurally. And type 1.5, I think also for different reasons, not a candidate. There are lots of topics I'll try to quickly go through: patient selection, imaging, timing of surgery, restrictions, if any, surgery and postoperative care. Classic symptom, I think you have to hear occipital headache with or without cervical pain, almost always Valsalva induced, wind instruments, coughing, sneezing, weightlifting. There may or may not be then a host of other symptoms: weakness, numbness, tingling, imbalance, eye findings, swallowing problems, tinnitus, and then scoliosis with syrinx. I don't know if this will come up later. We have yet to determine if scoliosis without a syrinx is a Chiari symptom or not and should be addressed that way, but it won't be the focus of today's discussion. The non-classic or quote atypical headaches, frontal, bitemporal, probably not very good candidates for either types of Chiari decompression, though we do offer it sometimes, unfortunately. Patient selection, for me specifically, they have to have neurologic deficits or intractable pain and syrinx with or without progressive scoliosis. I have used 3 millimeters or greater, which is a Park-Reeves determination as what a syrinx is, and not a dilated central canal. If I look at my practice, I think many other people look at their practices, you should probably not be operating on more than about 10 to 15% of newly diagnosed Chiari malformations, because I think the vast majority do not have deficits, do not have pain, and do not have syringomyelia. There's a lot of arguments about imaging. Personally, I think a non-contrast neuraxis MRI is essential. You can't just know about the cervical medullary junction. You need to know if there's a syrinx. I think in our practice, about 10% of syrinxes were isolated to the thoracic region. And if you only did a cervical study, you might miss that. And if that was your indication to operate, you would have lost that information. You should visualize through the conus. I think having a tethered cord is actually pretty rare in my experience, but it's certainly nice to know up front if that's the case. I don't think you need to do a lumbar study if the conus is visualized on your thoracic study. You do need to visualize the brain. Sometimes people will come in purely with a cervical MRI or cervical thoracic because they presented with neck pain and that was the first study. If you're lucky, there is a scout system in the MRI which took at least 1 or 2 views of the brain. As long as you can show there's no hydrocephalus and no posterior fossa mass, tumor, supracerebellar or arachnoid cyst, things that can give you sort of an acquired Chiari that might be missed, then I think it's fine. If not, if you can't see it, you really should send them back for a MRI. Will you miss that rare leptomeningeal tumor case with a non-contrast MRI? You might, but I usually won't send someone back, especially if they need sedation for a contrast study. I'll accept that non-contrast study. But if things don't add up and you're suspicious, certainly think about that you have the wrong diagnosis. I personally don't believe in CSF flow studies. I know it's controversial. Some people do. I'll be very interested to hear what Dr. Fuchs says. I think they're hard to obtain. They're not always lined up correctly in the machine, and therefore I think the data you get sometimes is misleading. I think it's always an elective operation with rare exceptions. I don't restrict the patients. That always comes up in the question and answer session with the parents. Whether or not they're having surgery, I don't restrict their activities. I don't think there's any true evidence. I think long ago there was a study done. I never found the study. I think maybe it was presented in abstract form only and I think it came out of DuPont, but I could be wrong about that, where they looked at patients that arrived to a busy emergency center over the course of the summer with high cervical cord injuries, and they did not find, when they imaged those children or adults, that there was an undue number of people in that group with Chiari-1 malformations who did not know that they had Chiari-1 malformations. And I think the takeaway from that is they probably are not at greater risk for whatever reason. They're probably not.